Hi, I'm Chris M. Slowecki, Managing Editor of DIA Global Forum, and I'm in the media studio at the DIA 2024 Global Annual Meeting with Courtney Shihabuddin, one of our patient partners for the Global Annual Meeting this year. So Courtney, I've had the chance to talk to you long before the camera started rolling. Thank you very much for being here. I think the first question would be, would you please introduce yourself and some of the different organizations that you work with and the work that you do?
Sure. As you mentioned, my name is Courtney Shihabuddin. Thank you so much for having me. It's an honor to be here as a patient advocate. I am by training a nurse practitioner, and I am a breast cancer survivor myself. And so I have kind of a unique experience of being both a patient and a provider. And after my diagnosis of breast cancer at the age of 35, I kind of struggled to wrap my head around what that would look like as a young woman with breast cancer. And it also coincided with the pandemic, so there weren't a ton of resources for me to utilize during my treatment. And so I felt once I made it to the other side that I really needed to utilize my knowledge and my voice to help other young women not feel so afraid and scared in a time that is so terrifying to a young woman with a new diagnosis. My mother is a survivor, and she was diagnosed when she was 49 years old. It was a very different treatment and life experience than myself at the age of 35 with a 1-year-old and a 5-year-old, and just kind of not only navigating treatment, but fertility preservation. How am I going to navigate going through cancer treatment with young children? There's a pandemic at the same time. And so I felt pulled to use my position and my privilege to help navigate that for others. And so I turned to social media, and I connected with organizations that offered guidance. There was nothing in person at the time due to the pandemic. And so I connected with organizations like Living Beyond Breast Cancer, and I was chosen to participate in their Young Advocate program, which was a year-long term where I was able to have media training and go through grant proposals for different clinical trials and lend my voice as a patient advocate and give feedback. And that was truly a great start of, here I am, this woman who's going through this horrible thing, but I'm able to connect with other young women, and we collectively are able to use our voice and share our experience to help hopefully shape future outcomes for others.
Right.
And since then, I've worked with organizations like Know Your Lemons, which as a provider, I truly love because they are a visual organization. They show what breast cancer abnormalities look like on lemons. And
that's remarkable.
It's really fantastic for me to pull up their app when I'm in with a woman who has a concern about her breasts and say, these are the things that we're looking for. Here, look at them. Or, these are the things that we're feeling for. And, we're looking for hard things that feel like a lemon seed, because that's tangible. That's something that a patient can feel and know. But things that look or feel like a kidney bean or a pea that are softer and more well-rounded, we're not really worried about those things. So if you feel those, then it's probably a benign finding. But it's really a visual way to explain to the lay population what to be concerned about. And so I truly adore that organization.
That's fantastic.
Because it provides this tool that can empower you to know your body. And as a young woman with breast cancer who was diagnosed prior to when screening recommendations said I should have been screened at the age of 40, had I not known or been able to advocate for myself, I may have not made it to my 40th birthday. And so my passion is not letting that happen to others.
Oh my gosh.
And I've translated that into my professional work as a professor of nursing. I teach my students all about, the guidelines say this, but you have to know these things too.
Where do you teach?
At Ohio State University.
Excellent, thank you.
And therefore, I'm educating the next generation of nurse practitioners to have this knowledge that just because the guidelines say 40 doesn't mean that you shouldn't listen to your patient when they say, I found this thing and I'm young.
Yeah.
And I've translated that into my work with my consulting firm at BJE Consultants. As our chief quality officer, I work with our clients to ensure that the patient voice is being heard and translated into whatever project we're working on for them, because the patient should be considered at the time of feasibility, not at the time of going to market, right? Yeah. And even when constructing clinical trials, you have to think about your patients as not just a number in your trial, but as a true participant. And how, if you treat them that way, your retention's going to be better. They're going to share about their experience. They're going to remain active in that care. And that's so important for not just breast cancer patients, but all patients across all trials, across all diseases or oncology. I mean, it's just so important. And so, yes, I wear a lot of hats, but I feel so passionate as a patient advocate about so many different areas that I need to have them all.
Yeah. Well, there's a lot of different connected things. Would you share your work with the Pink Warrior?
Yes. So in 2022, after I was in remission, I wanted to have a place where I could share my experience and guide other people who came to me mostly through social media on Instagram, asking for resources or help. And so I've written numerous articles. I have links to organizations that I feel really offer resources, not just for young women, but for community engagement, for scholarships, for treatment, for fertility preservation, or for reconstructive surgery if they can't afford it, how to ensure that they can receive that aspect of their care. And so my website, the Pink Warrior, offers not only these, what to expect with radiation therapy or how to manage side effects of your chemotherapy, but also these are some great organizations, the Young Survival Coalition, the Breasties, places that offer community support in person, online, just various aspects. I wanted it to be a place that people could go to get the knowledge that I so desperately wanted at the time of my diagnosis that wasn't available.
So I would like to give you a chance to share one or two stories of where you have seen your work make a difference in other people's lives. But before I do, I'd like to go back to your diagnosis for a moment.
Absolutely.
Just because of the circumstances, I think the best of us were feeling isolated during the pandemic.
Yes.
And then to layer that diagnosis in, to lay that, I mean, I don't think it's for dramatic effect, to lay that burden on you.
Yes.
During a time when we were all feeling isolated.
Yes.
I'm sure it's a painful time, but I'd like to give you the chance to talk to that.
Sure.
So that the next, God forbid there's another pandemic, but somewhere out there, a woman is going to get the diagnosis and feel alone.
Oh, yes.
And I'd like to just, before we
Sure.
ask you to turn to, here's where I've made a difference.
Yes.
Just revisit that time of your life briefly with me.
So I am a nurse practitioner. I have all of this medical knowledge. My mom is a 3-time breast cancer survivor.
Wow.
3 new growth breast cancers, not recurrence. And my father's sister is a 2-time breast cancer survivor. Her cancers were about 50 years apart. And so I knew that there was a significant risk for myself. And we've had genetic screening and nothing comes up. But my lifetime estimated risk of breast cancer was 57%, which is astronomically high, especially not having any genetic abnormalities.
Right.
So my OBGYN recommended that I go into a high-risk screening program, which I knew about because I'm a provider, right? And so I ensured that I was part of that program, and I was getting MRIs and mammograms annually, separated by 6 months. So I had some type of imaging every 6 months to screen. And that started when I was 24.
Okay.
When I had my first lump that I felt, that was my first biopsy, and it was followed since that point. So when I went in February of 2020 for my annual MRI, I then had to wait an hour and a half to meet with my physician to get the all clear.
Oh my gosh.
And she came into the room with this look. And she said to me, Courtney, your imaging is grossly abnormal from previous imaging.
Okay.
And we need to schedule biopsies. I'd like you to go right now for an ultrasound so that we can see if we're looking at something solid or if we're going to need an MRI biopsy. And so I did that. And they wouldn't let me see the ultrasound, which, you know, I feel like you have this knowledge, right? So they wouldn't let me see it. And then we scheduled the biopsy. And I had the biopsy. The way that I was positioned, I could see the screen. And the second I saw my tumor, I knew.
Okay.
It was, my diagnosis was invasive lobular carcinoma. And the word invasive, I mean, that's what it looks like. It had tentacles almost going into the surrounding tissue. It was not well circumscribed like a kidney bean would be, right? It was messy. And they did the biopsy and it came back as cancerous. I was teaching a class at the time and I saw that the OSU Medical Center was calling me. I excused myself. I answered the phone. They told me that I had cancer. And then I had to go back to teach class.
Yeah.
That was quite traumatic. I was not successful at teaching my class, let me tell you. And they told me, you know, the surrounding area had significant enhancement, meaning, you know, it looked abnormal on the MRI. And because I had a confirmed cancer, they wanted to do 2 additional MRI-guided biopsies, which I had to wait 2 additional weeks to schedule. So I had those. They wouldn't let me see an oncologist for a consult until all of the biopsies were complete, because that was how they were going to come up with the plan. So I saw a surgical oncologist who told me, you know, the only real option here is a double mastectomy. Ironically, I had a consult for a prophylactic double mastectomy scheduled for April of that year.
Okay.
I didn't make it that far. And so that was my treatment, a double mastectomy. It was scheduled for April 16th of 2020. And on March 31st, I saw my medical oncologist for the first time. I pulled into the parking lot and I got a phone call from the medical center and I answered it. And it was my surgical oncologist telling me that they were canceling my mastectomy because of the pandemic. And that they knew that I was going to see my medical oncologist, and because my cancer was hormone positive, his recommendation was that they put me on hormone therapy until the pandemic was over and they could reschedule my surgery because it was not considered a life-saving procedure.
Oh.
And I was devastated because I know how fast cancer can grow. And I know that it wasn't there 6 months ago, and it was already measuring 2 centimeters. And I have all of this medical knowledge in my head, and I was devastated.
Yes.
So I walked into my oncology appointment. I told her I just got this phone call. She excused herself. She left the room 15 minutes later. She came back and she said, your surgery's on Monday.
Great.
She saved my life.
Yeah.
She advocated for me. And despite the pandemic and the fact that whatever panel had looked at my surgery and said, well, her cancer's only on one side, and you're trying to do a double, so that's not essential life-saving procedure.
Okay, all right. I can at least see that logic.
Theoretically,
if not
but I
agree with
had
it. Yeah.
my 50% of the breast tissue on my left side came back precancerous.
Yes.
So it was everywhere,
Yeah.
regardless of what the actual pathology showed at the moment. So that was a really scary time.
Yes.
I would also like to add that my husband is an emergency medicine physician.
Okay.
And so he couldn't not work because there was a pandemic,
Oh.
right? So I had a 1-year-old, I had a 5-year-old, I lived in Ohio with no local family. My parents were stuck in Asia on a cruise around the world for their 50th anniversary and couldn't get home. I had no one to take care of me. My husband couldn't take off of work. It was just this, what do they call that? Like, all the things working against you, and how are you going to proceed? And what choice did I have? I had surgery. My aunt, God bless her, got in the car and drove from New Jersey with all the rest stops closed and no bathrooms or anything, to take care of my kids so that I could recover. And it was a really difficult time, but I was blessed in that my surgery, the high-risk program caught my cancer at the age of 35 before it had spread to my lymph nodes. And I was a stage 1B invasive lobular carcinoma patient, and my treatment was surgery and hormone therapy. No chemotherapy, no radiation. And I'm blessed in that regard because so many women don't have that, right? Especially when we look at our minority women. Black women with breast cancer are 4 times more likely to die than white women. And it's, why do we have that disparity?
Yeah.
Right? So now that I'm on the other side, my work as a survivor, as an advocate, as a healthcare provider, as an educator, is to help decrease that disparity in our care and help facilitate that for my patients, to teach my students that we have this, they need to be on the lookout for it, and we need to fix it, because there is no reason that a black woman should have 4 times more likely a chance of dying of breast cancer than a white woman.
I'm going to get back to that.
Yes.
But you have given me a great opportunity. I don't know who this nurse was, this advocate was, but I want to thank her on camera.
Yes.
And I also want to ask you then, let's flip that. Give me 2 examples of where you have been that nurse for someone else.
So I had, there's an organization called the Breasties, and they have local chapters. So I was at an Ohio Breasties meetup, and there was a woman who I hadn't met who was there. She had just had a double mastectomy. She was 31 years old, and she had had her drains removed that morning. Had gotten her pathology report, had no idea how to interpret it. Everything gets released through my chart, right? So no one had called her. No one had told her what her prognosis was. And she was there because she didn't know any other young women with breast cancer, and she felt like she needed community. This was recently. And so she sat next to me. We talked a little bit. And I asked her, where are you on your treatment journey? She told me, and she said, I really don't know what the rest of this is going to look like. I got this pathology report. I don't know what it means. So I said, would you like me to look at it? She was like, yes. So I looked at it. I mean, it was pretty devastating. She had 27 lymph nodes had been removed. Over 17 of them had come back positive for cancer. She had no idea. This cancer was who knows where. What was her next step? What could she expect? No one had communicated that with her. And while I'm not her oncologist,
Yeah,
I'm not
yeah.
on her team, I could say, you're going to need more scans. You're going to need chemotherapy. You may need radiation. You're 31 and single. You should think about fertility preservation. You should think about who your support system's going to be, because this is going to be a long journey. And she said she felt like she was drinking from a fire hose. And I
Yeah.
turned off the tap.
Yeah.
And after that, we stayed in touch. I helped connect her to an organization that you could apply for a scholarship to pay for fertility preservation, which she was able to get. So they paid for all of the IVF drugs and treatment. They flew her to New York for an egg retrieval procedure, and they are banking her eggs for whenever she may need them. And that's paid for from this scholarship. And I mean, because these procedures, the storage alone, I mean, it's thousands of dollars.
Yeah, that's an aspect of this with women that I never even consider.
Yeah.
Yeah.
And especially with young women. I
Yeah.
mean, the
Yes.
traditional breast cancer patient is not a young woman. It's
Right.
it's a postmenopausal woman who's had their children, who doesn't need to think about these things.
Right.
They don't have young kids, or they don't have to think about preserving their fertility in case they want to have kids. And it's a much larger conversation than just let's get the cancer out and treat it. There's so much other stuff. And so, I advocated for her to connect to these organizations. I helped her. She got that done. She started her chemotherapy. I brought her food. I brought her, blankets and socks and just things to keep her comfortable during her infusions. And now she's almost done. She's doing well. She has a good prognosis, but it was not an easy journey for her. But it's little things. I mean, was that this big effect of my advocacy? No, it was one person. But one person at a time, over time, can make a huge difference.
It's the starfish thing, right?
Yes.
The guy picks up 10,000 starfish on the beach. I can't pick them all up, but I can pick them up one at a time. Lost my mom to stomach cancer in 2018.
So sorry.
And I haven't heard the word infusion in a while. And it's funny, the emotional response I had to the word infusion. No, it's a good reminder that this doesn't go away. Even when you're through treatment, there's a ripple impact. That is a remarkable story. And I am honored to have been in the room when you shared it. You have a unique perspective, and I warned you about this question, but I think I'm going to phrase it differently. I guess I would ask it in two parts. You have a unique perspective. Where's the biggest disconnect in breast cancer between clinical research and clinical care? And then the second question is, what specific where in breast cancer, what's the biggest research need that you see in breast cancer right now? Is there low-hanging fruit we could be going after, or is it more strategic? So just the relationship between research and care, and then specifically, where would you like to see breast cancer research go?
So a lot of the work that I do academically is about sexual and gender minorities and the disparities in care. But I think when you look specifically at breast cancer, or really any trial of any kind, the people recruiting the patients need to look at the population that is affected by the disease and enroll a diverse, and by diverse I mean they need to enroll the patients that are affected by the disease, not just patients with the disease who are easily able to make it into the trial.
Right.
right? So we're looking at, there are a lot of people affected who have a lot of health disparities, whether they're socioeconomic, whether they're insurance related, whether they're access to care, whether it's simply a knowledge deficit, right? It's not just the people who are looking to get into the trial who may be coming from a place of privilege, which is what we often see in clinical trial participants, right? So my ask is to go to the recruiters and ensure that they are recruiting those patients that are really truly affected, who really need that care, who may not even know how to get to that trial.
Right.
So work with your advocacy groups. Go to the patient population and find out why that person can't get to that trial. Is it transportation? Is it they can't get off of work because they'll get fired if they don't show up? Is it they need a bus pass? Is it whatever it is?
They need someone to watch the children.
Childcare.
Yeah.
And provide that so that those patients who really need that care can make it into that trial.
So, my gosh, it's like you connected the dots in my brain before I had a chance to connect them. So we're in the exhibit hall here at the
Yes.
Global Annual Meeting, and there's a company here that specializes in arranging travel for patients to get to
wonderful.
clinical trials, which is a great segue into my last question. So you're here at the Global Annual Meeting as a patient partner.
Yes.
What are you hoping to accomplish here, and what are you hoping to take home from here in your work? I'd like to give you the chance to maybe talk about your next steps.
Yes. So the meeting has been phenomenal because as a patient advocate, I'm able to connect with the sponsors, with the CROs, with the organizations that are doing the research and say, this is the direction that you need to move in to diversify your trials, to get those patients, right? And it's not just at, phase 3. It's at feasibility.
Yeah.
It's at the time when you are constructing the trial, right? So here's where you want to be. You need to work backwards from your goal to ensure that you have taken the correct steps to get you to a successful conclusion. And here, as a patient advocate, I can help you understand those hurdles that your patients are experiencing, because they're not just a case number. They're a human being with all sorts of other issues, whether it be childcare, whether it be transportation, whatever it may be. Let's work together to make this more inclusive. Let's work together to diversify, to make access to trials more equitable. Because it's not just about inclusivity. You can be inclusive and still not be equitable.
That's a great point, yes.
And how do we fix that?
Yeah.
These conversations that are enabled by having people like me at this meeting to bring me to the table with those other people who are making those decisions. And that has been so vital. So thank you.
I can't imagine how this interview could have gone better, but I'm going to ask, is there anything I didn't ask you that you'd like to share?
So Chris, you asked me about where the biggest gap in research is.
Thank you.
I'd like to just go back to that for a moment.
Please do.
I think I'm going to speak specifically to breast cancer because that's my experience. That's where I do my advocacy work. Most of the clinical research that's done for breast cancer is done in the postmenopausal population because that is the greatest population affected by breast cancer. But there is the minority population of young women, and there is the minority population of metastatic breast cancer. And metastatic breast cancer is the only cancer that kills. And there's not enough research in those two segments because the young population may not respond to the treatments that exist.
Because they're developed for postmenopausal women.
And us
Right.
young women, we have lots of estrogen and
Right.
progesterone still, right?
I never thought about that.
And
yeah.
so the drugs just may not work.
Right. Right.
And we may need different drugs that we don't yet have. And because we are young and we don't necessarily meet the screening guidelines and we are not taught to check our bodies and look for abnormalities before the age of 40, when a woman who is young with breast cancer finally discovers it, it might be everywhere.
Yeah.
The young breast cancer population is disproportionately affected by metastatic disease.
Okay.
And they're the ones dying.
Yeah.
And that's a gap in clinical research and care. And we need more there.
Courtney, I can't imagine how this interview could have gone any better. I want to thank you for your time today. From the bottom of my heart, I wish you luck with your next steps.
Thank you.
It's just been great talking to you today, and I hope everybody at this meeting gets the chance to talk to you.
Thank you.
Thank you for watching. Thank you for listening. For DIA, I'm Chris M. Slowacki.